Okay, let's unpack this. You know that feeling when you're facing just loads of information, maybe getting ready for something big like exams, and you just need to drill down to the absolute essentials.
Yeah, to grab the really high-yield stuff that's actually going to stick.
Exactly. That's the mission for this deep dive, especially with complex medical topics, right?
Absolutely. It's not just about reading it, it's about getting what's most important and, well, why it matters.
Totally. So today we're diving deep into Aspergilloma, and we're using a specific set of MSRA revision notes as our guide here.
Think of it as navigating those notes to pull out the core facts.
Right. We'll go through the clinical picture, what it is, how it happens, who gets it, then, how you'd spot it, what you do, and the potential outcomes. Sound good?
Sounds like a plan.
All right, let's start right at the beginning then. What actually is Aspergilloma?
Fundamentally.
Okay, so the definition is it's a mass, basically a fungal ball that forms inside pre-existing cavities in the lung. A fungal ball? Okay, so it needs a space that's already there to grow in. What's it made of?
It's made up of the Aspergillus fungus itself, yeah, but also mucus and cellular debris. And this ball, this mass, it can cause inflammation locally and even damage the lung tissue around it.
And it doesn't just appear in perfectly healthy lungs then, it's linked to other problems.
That's a really, really important point, yes. It's very often associated with conditions that have already created those cavities. Things like tuberculosis, sarcoidosis, bronchiectasis, or maybe old lung abscesses.
So that pre-existing cavity is absolutely key.
Right.
Just for context then, where does Aspergilloma sit compared to other pulmonary aspergillosis conditions? Are there others we should know about?
Yeah, it's good to distinguish it. So you've got things like ABPA, allergic bronchopulmonary aspergillosis, which is more like a hypersensitivity reaction.
Okay, allergic.
Then there's invasive aspergillosis, which is, well, it's invasive, a serious infection, usually in people who are severely immunocompromised.
Right, much more aggressive.
And chronic necrotizing pulmonary aspergillosis, CNPA, which is sort of a slower subacute infection. Aspergilloma is specifically that picture, the fungal ball sitting pretty passively inside a cavity.
Right, the ball in the cave idea. That actually helps keep it clear, a good visual.
Yeah, exactly.
So thinking about why it forms there, the etiology, it sounds like it's all about the fungus getting into that space.
Precisely. It's caused when Aspergillus spores, which we all inhale, manage to colonize one of those existing lung cavities.
And like you said, that often happens because of those pre-existing conditions, TB, sarcoidosis, bronchiectasis, creating this space in the first place.
Exactly. And there's also a specific group that's at higher risk.
Oh, yeah. Who's that?
People who are immunocompromised. So that includes individuals with poorly controlled HIV infection or people who've had organ transplants.
Okay, so summing up the risk factors.
Yeah.
You need the cavity, often from TB, sarcoidosis, etc. Or you need a weakened immune system, like an HIV or post-transplant. That makes it harder to clear the spores.
Yeah, that combination really sets the stage for it.
Now, this is where it gets really interesting for me, the pathophysiology. How does the fungus actually, take hold and cause trouble inside that cavity?
Right. So it starts with those inhaled spores finding their way into the cavity and, well, starting to grow. They form that dense ball we mentioned, fungal hyphae, tangled up with mucus and debris.
And it's not just sitting there doing nothing, is it?
No, definitely not. Its presence and the fungus itself irritates the lining of the cavity. This leads to local inflammation, erosion of the lung tissue around it, and this is really key. It often leads to bleeding.
Ah, bleeding. Right, so the hemoptysis we'll talk about later comes directly from this erosion. What about the body's reaction? Does it fight back?
Well, the immune system tries. It attempts to sort of wall off the infection, but this response itself contributes to chronic inflammation and the formation of fibrous tissue around the area.
And what happens if someone is immunocompromised?
Well, their ability to control the fungus is much reduced. The fungus produces toxic stuff, metabolites, and often these patients are on therapies like steroids, which further suppress the immune response. So it's much harder for their body to contain the aspergilloma.
Wow, okay. Sounds like a bit of a vicious cycle there.
Yeah.
All right, let's switch gears a bit. If you suspect Aspergilloma, maybe based on symptoms or history, what else could it be? The differential diagnosis.
Absolutely critical step. Yeah. If you see something on imaging that looks like a mass in a cavity, you have to think about other possibilities. Key ones mentioned are lung cancer.
Okay, makes sense.
Active pulmonary tuberculosis, other kinds of lung abscesses, or even other types of fungal infections.
Right, other things that make a lump or fluid in the lung space.
Exactly. And then thinking more broadly about pulmonary aspergillosis, depending on how the patient presents, you might also consider things like asthma, bronchiectasis again, eosinophilic pneumonia, even conditions like granulomatosis with polyangiitis, other opportunistic infections if they're immunocompromised.
Hmm.
And of course, TB and sarcoidosis pop up again because they can cause the cavities or present in other ways too.
So let's take an example. Imagine you have a patient, long history of sarcoidosis, suddenly starts coughing up blood. Based on what we've just covered, risks, differentials, what's high on your list?
Well, your first thought, given the history of sarcoidosis creating cavities, should definitely be Aspergilloma forming in one of those cavities. Big possibility. But you'd absolutely need to rule out active sarcoidosis itself causing problems. Lung cancer is always a possibility. Or maybe even TB reactivation if that fits the picture. That history of a cavity really points you towards Aspergilloma, though.
Great point. That history is key. Okay, moving on. Epidemiology. How common is this actually?
Well, the source material notes that we don't have really solid prevalence figures specifically for the UK.
Okay, so not something tracked like, say, flu numbers every year.
Pretty much, yeah. But globally, it's known to be more common in places with a high incidence of tuberculosis, especially developing countries.
Ah, okay. And that links straight back to the risk factors, doesn't it?
It absolutely does. The amount of Aspergilloma in a population is pretty directly linked to how much cavitating lung disease, especially TB, is around.
Makes sense.
Mm.
So let's talk about how it actually presents. What are the clinical features you might see?
Okay, one really key thing up front. Many people with Aspergilloma don't have any symptoms at all. They're asymptomatic.
Really? Asymptomatic. How would you even find it then?
Often, it's just an incidental finding. You know, they get a chest x-ray for some completely different reason, and there it is, this thing in a cavity they might not have even known they had.
Wow. That really hammers home the importance of knowing someone's past medical history, doesn't it? But what about those who do get symptoms?
Right. For those who are symptomatic, the common things listed are a chronic cough, maybe some chest pain, shortness of breath, and sometimes recurrent chest infections.
Okay.
But the symptom that really stands out, the one you absolutely want to remember for Aspergilloma, is hemoptysis. Coughing up blood.
Hemoptysis, how common is that and how bad?
Yeah. The source says it can happen in up to 60% of patients. And importantly, it can be severe, even life-threatening. Interestingly, things like cough or fever are actually noted as less frequent than hemoptysis.
60% with hemoptysis. And it could be severe. Wow. That feels like a massive red flag, especially if you know someone has lung cavities. The notes also mention it in HIV patients with a history of pneumocystis jirovecii pneumonia. I guess PJP can leave cavities too.
That seems to be the connection, yeah. So definitely, if you're thinking high-yield revision points, hemoptysis is the big one to associate with Aspergilloma. Put a star next to that.
Got it. Hemoptysis plus cavity history. Think Aspergilloma.
So if you are thinking Aspergilloma, how do you actually confirm it? What are the key investigations?
Usually starts with imaging. A chest x-ray might show a rounded opacity, sort of a shadow within a cavity.
Is there anything specific to look for on that x-ray? A classic sign?
Yes, the notes specifically mention looking for a crescent sign.
Crescent sign, like a little moon shape. Is
Yeah.
that air trapped between the ball and the cavity wall? Exactly that. It shows there's air surrounding this mass inside the cavity. But usually you need more detail than an x-ray, so a CT scan, computed tomography, is the next step.
Right. Why is the CT so important here?
Well, it gives you a much clearer picture of the mass itself, the cavity structure, everything. And there's a really highly suggestive sign you often see on CT. Mobility.
Mobility.
Yeah.
The fungal ball moves. How do you check that?
Often they'll do the CT scan with the patient lying flat on their back supine and then also lying on their front prone. If that mass shifts position within the cavity depending on how the patient is lying.
Ah, like rolling around inside?
Exactly. That mobility is a very strong clue that it's a loose body like an Aspergilloma and not, say, a solid tumor attached to the lung wall.
Okay, crescent sign on X-ray, mobility on CT. Those sound like really crucial diagnostic pointers. What else? Any lab tests?
Yeah, you typically send off sputum samples for culture, trying to actually grow the Aspergillus fungus. Blood tests are important too. They help check the patient's immune status. And you often find elevated serum precipitin levels to Aspergillus species. That shows the body has been exposed and is mounting an immune response.
Right, so putting it all together, imaging X-ray, then CT, looking for that crescent and mobility, sputum cultures for the actual bug, and blood tests for the immune reaction. Makes sense. So once you've got the diagnosis, how do you manage it? What are the options?
The approach to management really depends on how symptomatic the patient is and their overall health.
So not just one standard treatment.
Not usually, no. For cases where it's mild or maybe completely asymptomatic, like we
The
discussed.
incidental findings.
Exactly. For those, the notes suggest that just observation, keeping an eye on it without immediate active treatment, might be the right way to go.
Okay, when would you step things up?
Well, the main options are antifungal medications or surgical removal of the aspergilloma. Surgery resection is considered, but mainly for patients who have decent underlying lung function, what they call acceptable pulmonary reserve. They need to be fit enough for the operation.
Right, because they might already have lung damage from whatever caused the cavity.
Yeah.
What about the medications?
Long-term oral itraconazole, an antifungal, is mentioned. It seems to be effective in around 60% of cases, according to the source. They also briefly mention that things like intercavitary catheters, putting antifungals directly into the cavity, have been tried.
And what about that severe hemoptysis? Coughing up lots of blood sounds like an emergency.
It absolutely is, or it can be. Severe hemoptysis needs urgent action. That might involve something called bronchial artery embolization, where they try to block off the bleeding blood vessel.
Okay,
Or in some situations, it might even require emergency surgery to stop the bleeding.
that really underlines just how serious that symptom can be.
Mhm.
Thinking longer term then, what's the prognosis usually like for someone with Aspergilloma?
Well, the likely outcome is pretty variable. It depends a lot on the patient's underlying health, the size and location of the fungal ball, and whether any complications develop.
But if it's managed appropriately.
Yeah, with the right management strategy, the notes suggest the prognosis can actually be quite favorable.
That's encouraging. But you mentioned potential issues, complications.
Yes, absolutely. There's still the potential for ongoing respiratory symptoms and for complications to arise down the line.
And the biggest danger, the one that keeps coming up.
Massive hemoptysis. It's highlighted again here as carrying a significant risk of mortality. It's the most feared outcome.
And the notes give some actual numbers on surgery outcomes.
They do, yeah. For surgical cases, they quote a 3.3% operative mortality rate, dying as a result of the surgery itself, and a 33.3% morbidity rate, meaning complications or problems related to the surgery. So it gives you a feel for the risks involved with operating.
Definitely puts the decision to operate into perspective. Okay, finally, let's just pull together the main potential problems. What are the key complications listed?
Okay, so recurrent respiratory infections are one possibility. Pretty straightforward.
Right.
Then the big one we've hit on multiple times. Severe, potentially life-threatening hemoptysis.
It really does dominate the risks, doesn't it?
It seems to be the major concern, and the mechanism behind it is also listed as a complication. The erosion of blood vessels within the cavity wall, leading to hemorrhage.
So the ball and the inflammation are literally wearing away at the blood vessels inside the lung cavity.
That's the process described, yes. Other complications include just general lung tissue damage from all that chronic inflammation and erosion.
And what about for those immunocompromised patients we talked about earlier? Any specific risks for them?
Yes, for them, there's a noted risk that the infection could potentially spread beyond the lung cavity to other organs or tissues. That's basically the progression towards invasive aspergillosis, which is, as we said, a much more serious systemic form of the infection.
Okay, so while many Aspergillomas might just sit there or need careful watching, the potential for really bad bleeding, ongoing lung damage, and spread in vulnerable people, those are the critical complications to have in mind.
Absolutely. Those are the key worries.
So wrapping this up, what does all this really mean? Here's something to think about. Based on everything we've discussed from these notes, Aspergilloma almost always sets up shop in lungs that are already damaged by something else.
Right.
How does that fundamental fact, dealing with both the pre-existing lung problem and the fungal ball, complicate things? Not just treating the fungus, but managing the patient's overall health, their breathing, especially when you start thinking about big interventions like surgery.
That's a great point. It means you're almost never dealing with someone who has perfectly healthy lungs to begin with. Their ability to tolerate surgery, for instance, is often limited by that underlying damage, and their immune status, which might be weak because of the original disease or its treatment, really influences how they handle both the infection and any intervention. It makes assessing the patient and choosing the right path incredibly complex. You're balancing multiple factors all the time.
It really does highlight why you need the full picture, the patient's entire history, not just the scan result.
Absolutely crucial, yeah.
Well, that was our deep dive into Aspergilloma, pulling out those high-yield points straight from the MSRA revision material. We really hope breaking it down like this helps lodge those key facts in your mind.
Yeah, focus on those main takeaways. The definition fungal ball in a pre-existing cavity. The risk factors, things that make cavities like TB or weaken immunity. The mechanism erosion causing bleeding, that's key. Classic signs on imaging, the crescent sign, the mobility on CT, hemoptysis as the major symptom and the major complication, and then balancing observation, antifungals, or surgery based on how severe things are.
Definitely. And if you're looking for more high-yield revision materials like the notes we base this on today, you can check out passthemsre.com and also freemsre.com.
Lots more resources over there for you to continue your own deep dives.
Thanks so much for joining us for this exploration today. Keep learning and keep diving deep.